My name is Attilio Olivieri. I'm involved in the transplant field, particularly in the treatment of patients with chronic GvHD. There are very important news about the pathophysiology and the treatment of patients with chronic GvHD, particularly in the biological field. Many important aspects have been recently elucidated, focusing on the role of the B-alloreactive memory cells, which can play an important role in maintaining the chronic damage and which are responsible of resistance to several treatments, particularly to the resistance of treatment with monoclonal antibodies, and also Treg compartment has been focused with a lot of drug or interventions, which has been demonstrated to be very active in expanding this population, which plays an important role in preventing the damage on the organ attack in a patient with a chronic GvHD. Moreover, new important compounds have been and are currently tested in the treatment of patients with chronic GvHD in order to block the non-immune effector damage, namely fibroblasts, neutrophils, and macrophages, which can play a relevant role in the final damage. Finally, another important aspect which has been elucidated is represented by the role of lymphocyte trafficking from lymph nodes to the target organs, and this phenomenon has been recently elucidated thanks to the identification of a master regulator of lymphocyte trafficking, which is represented by sphingosine 1 phosphate receptor, which can be effectively blocked by several drugs, particularly ponesimod. Ponesimod is an active drug in patients with multiple sclerosis, and in preliminary series it has been shown to be very effective in sequestrating lymphocytes inside of the lymphoid organ and to prevent the migration in peripheral organs. Among the Treg expanding agents, for sure, interleukin-2, ruxolitinib, and bortezomib represent the main important drugs which are currently being explored for treatment of patients with chronic GvHD, particularly interleukin-2 low dose has been pioneered by the group of Dana-Farber Cancer Institute, and an expanded study showed a very important response rate, and most interestingly, the biological data shows that Treg compartment can be effectively increased, and there was a sustained maintenance of the Treg levels together with a progressive normalization of Treg and T-con ratio. Ruxolitinib is another drug, very important, which is characterized by a pleiotropic actions. It is JAK1 and 2 inhibitors, and JAK family is very important for propagation not only of the inflammatory signals but also of the immune function, and some data suggest that the JAK-STAT signaling is also active not only in T cells but also in regulating B cell activity. Ruxolitinib has demonstrated to be very active drug not only in patients with acute but also in patients with chronic GvHD. Retrospective data suggest a very high overall response rate. Of course, this drug should be evaluated in prospective trials, and indeed there are two prospective randomized trials, REACH2 and REACH3, evaluating the efficacy of ruxolitinib both in acute and in chronic steroid refractory GvHD. So in conclusion, my opinion is that after decades of starvation in the treatment of chronic GvHD, now the better knowledge of pathophysiology of several biological steps of chronic GvHD allows us to approach the treatment, particularly the secondary treatment of chronic GvHD, with new drugs. And of course, the best option for these patients is to enroll them in prospective trial. And indeed, I would like to underscore the importance of stringent evaluation not only of the response rate according to the new NIH response criteria, but also a prospective established definition of failure criteria. This is very important in order to correctly evaluate the long-term outcome of these patients. Thank you.